Alright guys, it's Halloween over here in the United States. Well, not quite, it's not Halloween yet. I'm recording this before Halloween, but you know what I mean. And I'm just going to be making a video here about the antiarrhythmics. Now, the antiarrhythmics are very complicated, and I tried my best to keep it as simple as possible, but it's just a topic that's very hard to sum up. So, without further ado, I'm just going to get into the video. Just let me know below if you like this sort of content, because this video took a lot longer to make than my typical question videos, so it'll be very useful for you to know how helpful it was for you, so I could know if this kind of content is what you want to see. So hope you enjoy the video.
Alright, let's start with a straightforward question. A patient is given an antiarrhythmic resulting in the changes to action potential shown above as the blue line. Which of the following is the most likely agent given to this patient? Choice A, lidocaine. Choice B, verapamil. Choice C, adenosine. Choice D, metoprolol. Or choice E, amiodarone. And of course we have this image here with two curves on it representing two different action potentials, one before and one after the drug. And I know there's a lot of you out there who see questions like this and you just go, I have no idea what I'm looking at. So let's just take a couple minutes here to review our cardiac physiology before we dive into the antiarrhythmics. Of course, starting with the basics, we know that there are two different kinds of action potentials in the heart. There's the pacemaker potential and the cardiac myocyte action potential. Now, on these slides, I'm going to have way more written on here than I'm going to bother actually pointing out. Understand that my general goal here is to keep things relatively simple so that you can solve most USMLE questions. This is a very complicated topic, so it's difficult for me to choose where exactly to draw the line because we can always make it more complex and deeper. Anyway, like I said, we have the cardiac action potential here. There are 5 phases to it, 0, 1, 2, 3, and 4. Starting on the left here, we have phase 4 where it's in equilibrium, basically. It's similar to most cells in the body in that potassium is high in the cell and sodium and calcium is low in the cell and therefore high outside the cell. And this is because there's an equilibrium going on here between potassium mostly coming into the cell while sodium and calcium are getting pumped out. Now, like I said, we can make it more complex than this if we really wanted to, but let's keep it simple. Now, the cardiac myocytes usually contract as a unit, and that usually happens via gap junctions. So what will happen is that sodium will flow in from an adjacent cell usually, and that will cause it to reach a certain threshold and will cause a sudden rapid depolarization once it reaches that threshold. And that's where you get phase 0, where it's mainly sodium influxing into the cell. It's going to go up, up, up until we reach phase 1, where the sodium channels largely inactivate and the potassium channels open, which allow potassium to influx and the cell begins to repolarize, which is what causes this downward notch at phase 1. However, soon phase 2 happens where the L-type calcium channels open and calcium will flow into the cell even as potassium tries to exit. So what you end up with is positive charge coming in via calcium and positive charge leaving via potassium overall. And that causes this plateau phase at phase 2. Now eventually the calcium will basically run out, so to speak, and the calcium channels will close and potassium is free to keep exiting the cell, which will continue the repolarization of the cell, resulting in this downward slope at phase 3. And eventually we'll reach back to the negative charge state, which is the baseline status of most cardiac myocytes. Now some of you might be slightly confused about the transition between, for example, phase 3 and 4. You might be thinking, well, at the baseline phase 4, I have really high potassium in the cell, so how can that be possible if in phase 3 I was letting potassium leak out of the cell constantly? And that is very correct of you to point out, and that's because of how we decided to simplify the concepts so that we can present them to students and just for easy everyday understanding. It is in fact more the case that during the course of phase 3, certain potassium channels will close and certain ones will open that will help to facilitate it returning to the baseline level, which is where potassium is very high in the cell. And of course there's a short refractory period as well, where another action potential cannot happen, in part because it's trying to return to that equilibrium ion balance that it has during phase 4. Now, like I said, despite that being the case, it's still better for various reasons for you to just understand this in a very simple manner. So phase 4, equilibrium between potassium, sodium, and calcium going in and out of the channel with potassium high inside and sodium and calcium low inside. And then you have phase 0, where there's a sudden rapid depolarization because of sodium influx into the cell. Phase 1, potassium starts to leak out of the cell, causing a notch downwards. And in phase 2, calcium starts to come into the cell at the same time as potassium leaving the cell, which causes this equilibrium plateau phase. And then eventually the calcium runs out during phase 2, and you'll get phase 3, where potassium continues to leave the cell, which repolarizes the cell. Again, let's keep it simple. Alright, let's move on. Next we have the cardiac pacemaker potential. This is called the pacemaker potential because it doesn't need some kind of input to keep it going. And as you might expect, this is the kind of potentials that you'll find in the cells of the SA node and the AV node. And it's actually a lot simpler because there's only 3 phases. It has phase 0, phase 3, and phase 4. It doesn't have phase 1 or 2. So similar to the myocyte potential, you start with a phase 4, but there's actually no equilibrium going on here. If you'll notice, there's always a slight angle to phase 4 in the pacemaker potential. And to keep it simple, sodium and potassium are influxing into the cell during this phase, with the sodium influx famously being called the funny current. But for our purposes, we just need to know that sodium and potassium are flowing in until you reach the threshold, and then you'll have the sudden upstroke. Now, unlike in the cardiac myocyte phase 0, which was caused by sodium influx, here in the pacemaker, the phase 0 influx is actually caused by calcium. And then phase 3 will be similar to the phase 3 in cardiac myocyte potentials, where the calcium channels close and the potassium starts to flow into the cell, which helps it repolarize and prepares it for phase 4 again. So just a review for cardiac pacemaker potential, start with phase 4, where you have sodium and potassium slowly flowing into the cell. Then you reach the threshold, which causes phase 0, which is an upstroke caused by calcium influx. And eventually the calcium stops, and then you have potassium coming in for phase 3, where it repolarizes the cell in preparation for phase 4 again. So now that we have that out of the way, let's talk about the actual antiarrhythmics. So we have 4 main classes of antiarrhythmics. You have class 1, which is sodium channel blockers, class 2, which is the beta blockers, class 3, which is the potassium channel blockers, and class 4, which are the calcium channel blockers. Sometimes you hear people talk about class 5. That's not really a class per se, that's more just a miscellaneous basket that we like to throw all the leftover antiarrhythmics into. So let's just go in order here. Let's zoom in first on the sodium channel blockers. Now, some people like to hard memorize this stuff, and I'm certainly not against that in some limited capacity. But with the antiarrhythmics, if you understand the action potentials, then it's actually really easy for you to figure out what's going to happen to them if I block this channel or that channel. So we have a cardiac myocyte potential here. What do you think is going to happen if I block sodium channels? Well, ask yourself, what do sodium channels do in this action potential? And if you'll remember, sodium channels for myocyte action potentials cause the phase 0 upstroke that you see in the action potential here. So if I block sodium channels and therefore slow down the flow of sodium ions into the cell, then logically what this should do is lower the slope of this incline, right? So that's exactly what happens. What you have here is what happens when you give a class 1C sodium channel blocker. So on that note, let's talk about the different classes of sodium channel blockers. Now I'm going to take a page from a lot of other instructors and teach it in the order of CAB. And that is because that makes it a little bit easier to remember, because that arranges them in the order of strongest sodium channel blocking effect to weakest. So C is the strongest, A is moderate, and then B has the weakest. It also works well because, as you'll see in a moment, class 1C actually has the most straightforward sodium channel blocking effect. So first, let's fill out this table. We have the class 1C sodium channel blockers, which include flecainide and propafenone. As mentioned, this has the strongest sodium channel blocking effect, which slows depolarization. You can see the same image I had earlier. The effect on the action potential is that it decreases the slope on phase 0 because that's where depolarization is happening, right? So in terms of what happens at the EKG, it widens the QRS complex and also increases the PR interval. And this makes sense, right? Because what is the QRS complex? That represents ventricular depolarization, right? So if depolarization is slowed down, then of course the QRS would widen because it's taking longer for the ventricles to completely depolarize. And PR interval, same concept, right? Because what is the PR interval? The PR interval represents the time it takes for the electrical impulse in the heart to travel from the atrium to the ventricles. So if I have slower depolarization of all my cardiac myocytes, then of course it's going to take longer to reach there. Now, as far as adverse effects is concerned, the most important thing for you to know for class 1C antiarrhythmics is actually the fact that CAD and post-MI are pretty much absolute contraindications for usage of 1Cs. And that's because the slowed travel of the electrical impulse due to sodium channel blockage actually increases the odds of you developing a re-entry arrhythmia in the setting of a post-MI or CAD, because I have damaged tissue, and if the electrical impulse travels too slowly around that, you actually increase the risk of, for example, one side of the damaged tissue finishing their refractory period before the other side even finishes traveling. So what will happen is that when that slower side finishes traveling over, it might reach the tissue that just finished its refractory period and then therefore cause a re-entry circuit. Now, if everything I just said is complete gibberish to you, it's not super important for USMLE, so don't worry about it too much. But I do want you to take away the fact that class 1C antiarrhythmics are contraindicated if I have damage to the heart tissue, for example, CAD or post-MI. So moving on, we have class 1A antiarrhythmics, and this includes quinidine and procainamide. As I mentioned earlier, class 1A antiarrhythmics have a moderate effect of sodium channel blockage, but if you look at the image here, it looks like there's something more going on here. And that's because class 1A antiarrhythmics actually have the additional effect of moderate potassium channel blockade. So that's what's causing this slight shift of the phase 3 to the right you can see in the image here, in addition to a decrease in the slope of phase 0 that is not as profound as the decrease in slope from a class 1C drug. Now, recall that phase 3 is the part in the action potential where potassium is flowing out of the cell to repolarize it, right? So if I have a moderate potassium channel blockade, then yeah, of course, this part of the curve, phase 3, would shift slightly to the right because it's taking a bit longer because I closed off some of those potassium channels. Now, I feel the need to point out here that USMLE probably isn't expecting you to know this about class 1A antiarrhythmics, at least not to this level of detail. But I throw it in here because it's important for you to know that this is a thing, and to make you understand that we should not rigidly place all these drugs into the specific category they're in. Don't think that just because these are all class 1 antiarrhythmics that all they do is block sodium channels, because clearly they don't. So this potassium channel blockade will have a corresponding change on the EKG. So in addition to also having a QRS widening, although not as big as class 1Cs have, you will also have the usual finding of what you see with potassium channel blockade on EKGs, which is QT prolongation. And what you need to know about QT prolongation is that it is strongly associated with torsade de pointes risk. In addition, occasionally USMLE has tested on the fact that quinidine can cause synchronism, which is a combination of tinnitus, blurred vision, headache, and nausea. That's just one of those annoying side effects you have to remember. So quinidine, synchronism, make that connection. I've also noted here that procainamide can cause a lupus-like reaction. Not super high yield, but it's come up from time to time. So let's finally move on to class 1B here, which includes drugs like IV lidocaine and mixelatine. As I mentioned, this is the weakest of the class 1 antiarrhythmics in terms of sodium channel blockade. So you can see in the image here that the slope decrease is even less than both class 1C and 1A. And you'll notice that this too has an additional feature to it that wasn't found with either of the other two, which is that you can see that phase 3 has kind of shifted to the left a little bit. Class 1B antiarrhythmics actually cause a slight decrease in action potential duration and refractory period. The mechanism behind this is not well understood. There's a couple proposed mechanisms, but I don't believe there has been anything solidly backed in the literature yet. The only other things I feel like are worth noting is that because of how weak the sodium channel blocking effect is on class 1B drugs, you often won't even see a QRS widening on EKG, despite the fact that that is supposedly its mechanism, but because it's so weak, you can't even really see it on EKG. And in addition, because of how subtle of its effects are, it's actually the best choice for post-MI, kind of in contrast to 1C being the strongest effect and it being absolutely contraindicated post-MI. So now I'm going to jump past class 2 antiarrhythmics real quick just to talk about class 3 antiarrhythmics, because we just discussed class 1A antiarrhythmics, which included a bit of potassium blockade in its mechanism. So while that's fresh on our mind, that's actually pretty much exactly what you get with class 3 antiarrhythmics as well, which of course are the potassium channel blockers. As you can see, similar to the smaller effect you saw in the class 1A sodium channel blockers, you have a prolonged action potential here because it's taking longer for those potassium ions to flow out of the cells due to the potassium ion channels being blocked. And just like with class 1A antiarrhythmics, the biggest risk you have to think about with these class 3 antiarrhythmics is that they prolong the QT interval on the EKG, which is strongly associated with torsades of points risk. Now, while we're talking about the class 3 antiarrhythmics, I feel the need to single out amiodarone because USMLE seems to really like asking about amiodarone, at least more so than a lot of the other class 3 antiarrhythmics. So as I mentioned with some of the class 1 antiarrhythmics, you can't pigeonhole a lot of these drugs because amiodarone, even though it's classified as class 3, it actually has effects as a class 1, 2, and 4 antiarrhythmic as well. So because of that, when you use amiodarone, the changes on the EKG would not look the way you would expect it if you were thinking it's only a potassium channel blocker, because then you would only be thinking about the QT prolongation. But amiodarone also causes QRS widening. It causes PR interval increase. And even with the adverse effects, it kind of has a lot of differences. It notably causes pulmonary fibrosis and hepatic disease, but it actually has a pretty low torsade de pointe risk, which bucks the trend for class 3 antiarrhythmics. And they've actually mentioned that specifically on NBME and or Free 120 questions before. So I'm not throwing all this at you just to confuse you. Amiodarone is one of those weird exceptions that they actually like testing on. And I guess just as a bonus here, amiodarone is also a cytochrome P450 inhibitor. That could probably come up as well. So next I'm going to talk about the class 2 and class 4 antiarrhythmics together because their mechanisms are actually very closely related. So beta blockers, of course, block beta receptors, normally agonized by catecholamines. And if you're at all familiar with your autonomic pharmacology, you will know that the catecholamines can agonize beta receptors like beta 1 and beta 2, which are GS coupled receptors. So if I have a beta blocker, that means I have less activation of GS, which means less conversion of ATP to CAMP, less protein kinase A, less calcium influx, which is what leads to the lowered heart rate and contractility that you see when you give a beta blocker. So the effect on the EKG, as you might imagine, is that the PR interval might increase, but mostly you're just going to see a decrease in heart rate. And the adverse effects that result are pretty intuitive too, right? Because you'll have bradycardia, of course. AV block is possible. You can have what's called beta blocker withdrawal, which is basically if you take someone off a beta blocker after they've been using it for a long time, they will kind of get the opposite effects, right? They can get tachycardia. And of course, beta blockers can also cause bronchospasm because, well, remember, how do we treat asthma? We treat it with beta agonists, right? So logically, if I gave a beta blocker, it can have the opposite effect. And beta blockers can bring you down. They'll give you depression. As for calcium channel blockers, such as verapamil and diltiazem, by blocking the flow of calcium into the heart and blood vessels, I can cause the blood vessels to relax. I can cause the pacemaker potential shown here to slow down, right? So in the end, the effect looks very similar to beta blockers, where I have a decrease in heart rate and probably a PR interval increase as well. And similarly, I can have side effects of bradycardia and AV block. So finally, we arrive at type 5 antiarrhythmics, which is pretty much a miscellaneous category, as I mentioned before. And the two main drugs you want to know about in this category are adenosine and digoxin. Now, even though they have very, very different mechanisms, they actually end up having similar effects on the pacemaker and cardiac action potentials. So adenosine agonizes GI coupled receptors, which leads to calcium channel blockade and potassium channel efflux, which, given that the starting state of a cell is high in potassium with a low charge. If I efflux a bunch of potassium, that means I'm hyperpolarizing the cell. And what this means is what you see above in the image, which is where I'm essentially starting at a much more negative charge. It's hyperpolarized. So it takes me more time, keeping it simple as we said, to reach the threshold for an action potential in the pacemaker cell. And really the end effect here is that the heart rate goes down, right? Because it takes much longer for each action potential to happen. Now, similarly, digoxin's actions on pacemaker cells is to increase vagal stimulation, which ends up activating the potassium channels, which ends up in an effect that's very similar to adenosine, because you have increased potassium efflux. Potassium is leaving the cell, which hyperpolarizes the cell, and you end up with the same image you see above for the pacemaker cell. Now, this might be a bit confusing to some of you because for a lot of you, the bigger effect of digoxin you tend to hear about is the sodium-potassium ATPase inhibition that is performed by digoxin. And yes, that is what you tend to hear about a little bit more with digoxin, but you need to know that that is what happens in myocytes, not pacemaker cells. So it essentially has almost an opposite effect in myocytes in that it's slightly depolarizing those cells, right? Which is what we'll have on the image on the right here. Because since I don't have the sodium-potassium ATPase as active, I will not have 3 sodium ions being pumped out in exchange for 2 potassium coming in, which is a large contributor to what keeps the myocyte at a negative charge, right? And in addition, because the sodium-potassium pump is not functioning, that means the sodium-calcium exchanger as a result is also not really functioning, right? So that leads to an increase in calcium inside the myocyte, which is what causes the increased contractility that you associate with digoxin. Now, this image on the right here, you really don't need to know it. I just put it here for completeness sake, and you can get a visual understanding of what digoxin does to the myocyte. And similarly, you probably don't really need to know the EKG findings for adenosine and digoxin either, but I really want to hit home that your understanding of how they work can kind of help you intuit what these EKGs might look like. So for adenosine, it has a very strong hyperpolarizing effect, but it is very, very transient. So what you see with adenosine a lot of times is that there will be a transient asystole, so a complete cessation of all electrical activity on the EKG, with a slow return of the SA node, which is the P wave basically, and then normal complexes follow. And this is actually related to the adverse effects, so to speak, of adenosine, which is what you'll hear about in hospital a lot, is that when you inject adenosine, patients will have this impending sense of doom, is what they call it. Basically, the patient will sometimes say they feel like they're dying. And that makes sense, right? Because it's basically stopping your heart for like a full second. And similarly, one of the other more severe side effects of adenosine is that it can actually cause cardiac arrest. And because of how it works, it's also largely contraindicated if somebody has an AV block of some kind. Now, with digoxin, you don't get that sharp effect of adenosine, but it still hyperpolarizes the pacemaker cells, so of course you'll get a bradycardia. And because of its effects on cardiac myocytes, on the EKG, you'll see things like an ST depression, and that's because of the increased calcium in the myocyte will have this weird effect on how repolarization happens, so that ends up looking like an ST depression on EKG. And stuff like the increased PR interval and shortened QT interval are also things that you can kind of intuit from how digoxin works. And as far as adverse effects for digoxin goes, you've probably heard about them in your classes because it's often held up as this very cardiotoxic drug that we don't really use that much anymore. All kinds of nasty effects. It can cause arrhythmias. It can cause CNS and renal symptoms. One of the really buzzy findings you tend to hear about sometimes in the hospital is how it can cause yellow vision. None of these things are super important. I think it's more important that you have a general understanding of the mechanism of adenosine and digoxin, and from that you can kind of extract or intuit what the action potentials in EKGs would look like. So here's a summary slide. I know that was a lot, but like I said, this is even with me trying my best to keep things simple and straightforward. Antiarrhythmics is a very, very complex topic, and we can always get deeper into it. We can have like a 2-hour discussion about it. But now let's just take some of the stuff we just learned and apply it back to the questions we were just talking about. So let's just go back to this question I started the video with. I give a patient an antiarrhythmic and I cause a change in the action potential that I show in the picture above. So what's going on here? Well, right off the bat, you can immediately recognize that this is a pacemaker potential, right? Just because of the shape of it. You know that this is not a myocyte action potential because there's no plateau phase. And if you look at the blue curve here, what does it look like is happening? Well, I'm starting at a point that's way more negative than the normal curve. So that means this drug hyperpolarized this cardiac pacemaker cell. So let's look at the answer choices here. Choice A, lidocaine. Oh no, that's a class 1B antiarrhythmic, right? It's a sodium channel blocker, so logically what I would expect is a cardiac myocyte action potential with a slowed phase 0 upstroke. So just based on the fact that this is a pacemaker potential, I can cross off lidocaine. Choice B, verapamil. Oh no, that's a class 4 antiarrhythmic, right? So that's a calcium channel blocker. And what you need to remember is that class 2 and class 4 are kind of similar in what they do, in that yes, they tend to act on the pacemaker cells, but what they do is mostly decrease their heart rate. Class 4 being that because it's a calcium channel blocker, it decreases the entry of calcium into the pacemaker cell, which will delay it reaching the threshold and also probably slow the depolarization as well. So you would have a decreased heart rate and would have a harder time reaching the threshold, similar to the picture, but it would not hyperpolarize the cell, which is what you're seeing. Choice C, adenosine. Okay, I'm liking that one because what did we just discuss earlier? Adenosine hyperpolarizes cardiac pacemaker cells by promoting potassium efflux and preventing calcium influx. So let's take a look at some of the answer choices before we decide on choice C. So choice D, metoprolol. So of course, anytime you see the suffix olol, you should be thinking beta blocker, which for our purposes is a class 2 antiarrhythmic, right? Like we mentioned with verapamil, beta blockers function pretty similarly to calcium channel blockers in terms of antiarrhythmics. They can decrease the heart rate, but instead of blocking calcium channels, it blocks the effects of catecholamines like epinephrine and norepinephrine. And as mentioned, even though yes, it would also probably have a cardiac pacemaker potential as the image, very similar to verapamil, you would not see a hyperpolarization. You would just see a decrease in heart rate. Choice E, amiodarone. No, that's a class 3 antiarrhythmic, right? It's a potassium channel blocker. And as I mentioned earlier, amiodarone has effects spanning all types of different classes of antiarrhythmics. It's just that we primarily think of it as a type 3 antiarrhythmic. Not that it's relevant for answering this question anyway, but even if we just limited ourselves to class 3 antiarrhythmic function, it mainly prolongs the action potential in cardiac myocytes. So just this tracing is just the wrong type of cell in the first place, right? We should have a myocyte action potential, not a pacemaker potential when we're talking about amiodarone. And what you see with class 3 antiarrhythmic is that you'll see a prolonging of the plateau phase, which is phase 2 of the myocyte action potential. So our correct choice here is going to be C, adenosine. So before I leave you off, let's do another question, do one that's slightly harder, I would say. So a 55-year-old man comes to physician for random episodes of palpitations. ECG finds no abnormalities. Physician sends the patient home with an ambulatory ECG monitor and upon follow-up helps confirm the physician's suspected diagnosis. The physician prescribes an antiarrhythmic drug that is capable of affecting multiple different channels of the heart, as well as delays repolarization of the cardiac myocytes, with a relatively low risk of causing dorsades de pointes. Which of the following is associated with the drug most likely prescribed? Choice A, synchronism. Choice B, pulmonary fibrosis. Choice C, depression. Choice D, impending sense of doom. Or choice E, xanthopsia, or yellow vision. So obviously I made this more of like a second or a third order question. I'm asking you about the side effects. So let's just first figure out what we gave the patient, okay? So we have this patient that comes in with palpitations. ECG finds no abnormalities, and then the physician sends the patient home with an ambulatory ECG monitor, which confirms the diagnosis. This is more of a step 2 point, but you need to know that when a patient comes in with palpitations, possibly episodes of syncope and things like that, you should be suspecting paroxysmal atrial fibrillation. So that's why you send them home with an ambulatory ECG monitor to help you confirm that diagnosis, because the AFib is coming and going, so the ECG you're taking at the hospital might not tell you that. So obviously I was a bit of a jerk here and hid the diagnosis from you, but it should be noted that's not even really important for answering the question, because I tell you that the antiarrhythmic drug that I give is capable of affecting multiple different channels of the heart and delays repolarization of cardiac myocytes. So what does that sound like? Well, what ion do I need to repolarize in the cardiac myocyte? I need potassium, right? That's phase 3 of the cardiac myocyte action potential. So if I'm delaying repolarization, that probably means I'm using a potassium channel blocker. And as we talked about before, amiodarone is a potassium channel blocker primarily, but it also has effects on several different channels because it kind of has class 1, 2, 3, and 4 effects, which is what you need to recognize the question as describing here. And you need to know that class 3 antiarrhythmics, even though they're typically associated with QT prolongation and therefore torsade de pointes risk, strangely enough, amiodarone actually has a pretty low risk of torsade de pointe despite the fact that it is a class 3 antiarrhythmic, which is actually a testing point that has come up on the MBMEs before. So now we know we probably used amiodarone. So let's look at some of these side effects here and try to figure out which one is associated with amiodarone. Is it choice A, synchonism? No, that sounds more like quinidine, right? That's a class 1A sodium channel blocker. Choice B, pulmonary fibrosis? Okay, maybe. I mean, amiodarone has all kinds of different side effects. But even if I'm not sure, let's look at some of the other answer choices and try to figure it out from there. Choice C, depression? No, I don't really like this answer. This is more something we associate with beta blockers, right? Choice D, impending sense of doom. This is a very buzzy side effect that you need to know about adenosine, which is a class 5/miscellaneous antiarrhythmic. And you need to understand that adenosine causes this because it essentially resets the heart, quote unquote, and causes a transient lack of electrical activity, which is an asystole, which is likely associated with this impending sense of doom that the patient will have. And finally, choice E, xanthopsia, yellow vision. No, this is digoxin, right? This is a very buzzy side effect that we associate with digoxin. So even if I wasn't sure about the side effects of adenosine, all these other answer choices are pretty important for you to know as far as side effects of antiarrhythmics go. So our only answer choice here is choice B, pulmonary fibrosis. So I'll just end this video by throwing up a summary slide that I had earlier. Now this video is becoming half an hour long, which I think is probably past the point where a lot of you can keep your focus on a YouTube video. But if you enjoyed this, if you like content like this, please let me know in the comments below, because this kind of video is much more time consuming and difficult to make. But if you find value in it, I'll make an effort to try to make more videos like this. I hope you found this video helpful, and I'll see you in the next one.